Welcome back to A Doctor's Diary. Today we are discussing the comprehensive management of atrial fibrillation. Let's get started. Atrial fibrillation is the most common sustained cardiac arrhythmia. It is characterized by rapid and uncoordinated electrical activity of the atria. Because of this chaotic activity, the atria lose their effective contraction and the coordination between atria and ventricles is disrupted. As a result, the efficiency of the cardiac pump decreases. If left untreated, atrial fibrillation leads to progressive myocardial remodeling and eventually to chronic persistence of the arrhythmia. Let's look at how we classify this condition. Atrial fibrillation can be classified according to its duration. Paroxysmal atrial fibrillation refers to episodes that start suddenly and terminate spontaneously. Persistent atrial fibrillation lasts longer than 7 days. Long-standing persistent atrial fibrillation persists for more than 1 year. Permanent atrial fibrillation is present when rhythm control is no longer pursued or has failed. Accurate diagnosis is crucial. The diagnosis of atrial fibrillation is established using a 12-lead ECG. Typical ECG findings include irregular RR intervals, absence of P waves replaced by small fibrillatory waves called EF waves, and a very high atrial rate, usually between 350 and 600 beats per minute, with variable ventricular conduction. If the initial ECG does not show atrial fibrillation but clinical suspicion remains high, further evaluation may be needed. Evaluation may include continuous ECG monitoring for 24 to 72 hours or the use of an implantable event recorder. A detailed medical history and physical examination are essential. At this stage, the ATRA score can be used to assess the impact of symptoms on the patient's quality of life. Routine laboratory testing should include a complete blood count, electrolytes such as sodium, potassium, and magnesium, creatinine, TSH, and NT-proBNP when heart failure is suspected. Echocardiography is mandatory in all patients with atrial fibrillation. It helps identify structural abnormalities such as wall motion disorders or valvular heart disease. Now let's talk about thromboembolic protection. One of the most important complications is stroke. One of the most important complications of atrial fibrillation is thromboembolism, particularly stroke. Prevention can be achieved either through oral anticoagulation or by closure of the left atrial appendage, which is the origin of approximately 90% of thrombi in atrial fibrillation. Left atrial appendage closure is mainly indicated in patients with contraindications to anticoagulation. The procedure can be performed either percutaneously in a minimally invasive way or surgically. However, the standard therapy remains pharmacological anticoagulation. Before initiating anticoagulation, risk assessment is performed using the CHA₂DS₂-VA score and the HAS-BLED score. Anticoagulation is strongly recommended when the CHA₂DS₂-VA score is in 2 and relatively indicated when the score is 1. The HAS-BLED score estimates bleeding risk. A score of 3 or higher indicates increased bleeding risk, but it does not represent an absolute contraindication to anticoagulation. Choosing the right anticoagulant is key. Let's review the available options. Vitamin K antagonists, such as warfarin or fenprocuman, are indicated in patients with mechanical heart valves or significant mitral stenosis. Their effect can be reversed using vitamin K, prothrombin complex concentrate, or fresh frozen plasma. Direct oral anticoagulants include apixaban, dabigatran, edoxaban, and rivaroxaban. Their dosing depends on renal function. Factor XA inhibitors such as apixaban, edoxaban, and rivaroxaban can be reversed using andexanet alpha. Dabigatran has a specific antidote called idarucizumab. Because andexanet alpha globally inhibits factor XA, further anticoagulation should be performed using argatrobin or bivalirudin. Now we move to the 2 main treatment strategies. Our goals are stability and preventing persistence. The treatment of atrial fibrillation has 2 main goals. First, maintaining hemodynamic stability. Second, reducing the risk of chronic persistence of the arrhythmia. These goals are achieved through 2 therapeutic strategies: rhythm control and rate control. Rhythm control aims to restore sinus rhythm. There are 3 main methods available. 3 main methods are available: catheter ablation, antiarrhythmic medication, and electrical cardioversion. Catheter ablation is currently considered the most effective treatment and is therefore widely used. Most arrhythmogenic triggers originate from the pulmonary veins, and complete pulmonary vein isolation provides better outcomes. During the first months after ablation, recurrences may occur. A repeat procedure can be considered no earlier than 8 weeks later. However, the success rate decreases significantly when AFib persists for more than 12 months or when the left atrium is dilated. Another option is pharmacological cardioversion using class IC antiarrhythmic drugs such as flecainide or propafenone. These medications are effective but should not be used in patients with structural heart disease, prior MI, or heart failure. In such cases, amiodarone may be used for short-term rhythm control, although it has a higher rate of adverse effects. Flecainide is also used by some cardiologists as a pill-in-the-pocket strategy for selected patients. The third option is electrical cardioversion. Before any cardioversion, intracardiac thrombi must be excluded. Thrombi can be excluded by transesophageal echocardiography, CT, or MRI. If thrombi cannot be ruled out, patients must receive anticoagulation for at least 3 weeks before rhythm conversion. After successful cardioversion, anticoagulation must be continued for at least 4 weeks. In hemodynamically stable patients, a wait-and-watch strategy may be appropriate for the first 48 hours. However, recurrence rates remain high, reaching approximately 70% within 1 year after cardioversion. When restoration of sinus rhythm fails, the main therapeutic goal becomes rate control. The aim is to reduce hospitalizations and improve the patient's quality of life, usually achieved with medication. First-line drugs include beta blockers, such as bisoprolol, non-dihydropyridine calcium channel blockers, or digitalis. Amiodarone can be used as a short-term alternative when other treatments are ineffective. Digitalis's potential benefit may be mainly in patients with heart failure with reduced ejection fraction. Current guidelines recommend lenient rate control, targeting a heart rate of less than 110 beats per minute. Strict rate control is indicated only if patients continue to experience significant symptoms. If pharmacological therapy fails, AV node ablation with pacemaker implantation may be considered. This strategy is reserved for patients with permanent atrial fibrillation, heart failure, and repeated hospitalizations. Thank you for watching this deep dive into AFib management on a doctor's diary. If you found this helpful, please like, subscribe, and hit the bell icon. See you in the next one.